I'm very pleased to introduce you to Dr. Asenath Steiman. She is a geriatrician here at Sinai Health UHN. She received her medical degree from the Sackler School of Medicine in Tel Aviv, Israel, and completed her residency in internal medicine and fellowship training in geriatrics at Mount Sinai, Beth Israel in New York City. She has been a staff geriatrician here at the Sinai Health and the UHN since 2015. Her clinical work focuses on geriatric rehabilitation, and she works as the clinical lead for the Independence at Home community outreach team. I'd like to hand the presentation over to Dr. Steiman.
Hey, thank you so much, Cheryl. Thank you to everyone for having me, inviting me to speak at these Healthy Aging 101 sessions. It's really a pleasure to be here. So I thought we can jump in and talk a little bit about some of the objectives of what we're going to speak about today on these sort of chronic health conditions. So we're going to understand some common chronic health conditions and combinations of them that tend to occur as we age. We'll identify challenges that come from living with these and sort of managing these multiple health conditions. And we're going to recommend some strategies that we can try to improve this self-management. I really wanted to give a good amount of time more so on your questions. So we'll get through all of our our slides, my slides, but I really wanted to give a chance for us to have more of a discussion. I think that might be more interesting than me just reading off some slides. So hope you enjoy, and let's start. So what are chronic health conditions? So these are really conditions that are present over a long period of time. So these are conditions that people might have had when they were younger, and they sort of grow with you. Things like diabetes, heart and lung diseases. And remembering that these are things that are conditions that are not infectious. They're not ones that could be sort of passed, that come and go, like influenza, pneumonia, COVID. And so these are things that, again, you might be more familiar with, like arthritis, high blood pressure, cardiovascular disease. We'll get into some of the prevalence of these things and these conditions in our population. So those are sort of the idea of what we're talking about, certain chronic health conditions. First, I really wanted to talk a little bit about sort of the natural changes with aging, because these are sort of the physiological changes that happen naturally as we get older. And the reason that that's important is because certain conditions that we might have had when we were younger, and the treatment for them and the management for them when we were younger, might change as we get older because of some of these natural changes that we have. So just some examples are things like vision. So as we get older, we might have issues with vision, most commonly things like needing reading glasses. Things like cataracts is more common in older adults. Things like age-related macular degeneration. So those are things that can happen naturally as the lenses in our eyes sort of stretch, change. We have these vision changes. Another aspect of aging that can happen is something called proprioception, which is really that sense of our body in space, which sounds a little off and weird, but it's something that we don't really pay attention to until we have issues with it. And as we get older, this is something that we might find that we're not really, able to see where we are, and that could lead to tripping and falling and balance issues. You might also see this with not natural issues, changes, things like diabetes. People might have proprioception issues, but that's because of a chronic illness. This can also just occur naturally. Related to that is more of that something, if you might have heard of, called the vestibular system. And that's just a system of sensors in our body that helps us orient ourselves, in the spatial orientation, and has to do with balance. So very similar, related to proprioception, but a different system, a different route. And that might be things like inner ear. Vertigos are related to this, and that can also change as we get older, as these systems age with us. And I won't necessarily get into the details of it, but that's something that we do see quite often, and that obviously you can imagine the implications on one's day-to-day functioning with that. Another thing that we notice is decreased muscle tone. So you may notice as you get older, as one gets older, there is that natural weakness, or maybe that idea that we used to be able to do things, we used to be stronger, there's a little bit of weakness. Much easier to sort of lose that tone than it is to maintain it and gain it. So we do see that in older adults, and you can imagine how that might have an impact. Our regulation of blood pressure changes, and that can happen for multiple reasons. Could be some of the receptors in our body that sort of senses those changes in pressure become a little less sensitive. So that could lead to the body not being able to, sense the lower blood pressure. We get dizzy, we, fall, faint. That could also happen naturally as we get older. And you can imagine the impact of that if you've had, blood pressure issues when you were younger, as things sort of change. And we'll talk a little bit more about that, of how management might actually have a poor effect if we're, for treating blood pressure as we get older. And another aspect is sort of that dehydration picture. As we get older, we don't have that that drive for feeling thirst. And so it's sometimes much easier for us to get, as we get older, to get dehydrated. We see it more acutely when it's very warm outside. Older adults may become more dehydrated easier if there's acute illness. So you can see in summary that there are a lot of natural changes as we get older. And I want you to keep that in mind as we go into how do our chronic illnesses, et cetera, conditions change as we get older. So first, we'll just talk a little bit about what are some of these chronic health conditions and how prevalent, how common are they in our Canadians population. So on the left side, you'll see the prevalence of very common chronic conditions. So arthritis, oh yes, very, very common in older adults. And we're lucky that we have lots of joints in our bodies that can get arthritis. So common areas are our knees, hips, shoulders, hands, you name it, you can get arthritis there. And that, you can imagine, can cause a lot of discomfort, a lot of balance issues, a lot of implications other than just feeling uncomfortable and in pain. High blood pressure, that's also a quite prevalent chronic condition in older adults. You see it also in younger adults. Again, it grows with you. We also have cardiovascular disease. You can see 19% of older adults have some sort of cardiovascular disease, be that, heart conditions, be that strokes. So lots of options for cardiovascular disease in older adults as well. Diabetes, usually we think about the type 2 diabetes, which we develop, as opposed to type 1 diabetes, which is an immuno issue. So, diabetes is another big issue that we have as older adults. Cancer, unfortunately, is also quite prevalent as we get older. And then some respiratory issues. So COPD, asthma is also seen in older adults. On the right side, you see the prevalence of the combination of some of these chronic conditions. And, there's not necessarily a direct relationship between, high blood pressures and arthritis, although there may be some, relationships between these two things. But just to show some of the more prevalent health conditions that can happen, if you definitely can have combinations. And from experience, I'm sure you are someone who has sort of multiple conditions. So you can see high blood pressure and arthritis, 14% of older adults have that combination. Blood pressure, cardiovascular disease, high blood pressure, cancer, high blood pressure and diabetes. High blood pressure seems to be a theme here, and cardiovascular disease and arthritis. And I think the importance of this is just to show you that the combinations are going to be endless with older adults, and it gets complicated. And so we have to sort of see how can we help and manage these issues. So really, having multiple chronic health conditions can present with some challenges, of course. I would say that one of the things that I find when I talk with my patients is that the more issues that are identified, the more specialists they're seeing. And very often, and thankfully we have specialists, thankfully we have access to these specialists, but oftentimes their focus is so laser sharp on whatever that issue is. They're focusing on that atrial fibrillation, they're focusing on, the knee arthritis, they're focusing on that, diabetes, et cetera. And they're not necessarily looking at the patient holistically. So you have a lot of these specialists who are zeroing in on, a lot of very specific things, and that could lead to some issues. That could lead to, and you'll see written here, the use of multiple medications, oh yeah, this issue, wonderful. We have wonderful technology, wonderful studies, wonderful good efficacy for, use of this medication. But, everyone's not necessarily saying, well, how is that going to affect, the other issues that I have? So you have a lot of times that you'll have polypharmacy. Polypharmacy may lead to, inappropriate interactions that, while individually the medications or whatever the treatment is may be appropriate, they may not be thinking of all the interactions. And when that happens, you have to also think about not only interactions with other medications, but as we talked about earlier, the natural changes in physiology when we get older. So things that might work, and if someone might have been on a medication for their, let's say, hypertension for 20 years, and it's been working wonderfully. As we get older and things change with that natural physiology, or maybe there's more health conditions that sort of come on and there's other medications, things get complicated, things change, and that could lead, unfortunately, to things getting worse, harmful effects. And it could lead to things like an impact not only on your physical health, but on mental health as well. Leads to, if there's a decline in function, that can lead to, low mood, depression, reliance on other people, feeling helpless, feeling guilty, the effect not only on the patient themselves, but on the family, if there's increased caregiver needs. So it really has a big impact. So it's really the effect of having chronic multiple conditions, not only on the actual effect of the condition, increasing your, mortality or increasing your risk of heart attacks or whatever it is for whatever chronic condition, but it also could lead to, using multiple medications and things that are related to that, greater healthcare use, reduced quality of life, fragmented care like we talked about, and overall poorer health. So there really is sort of this, cycle and an effect that, stems from more than just having, your list of all your chronic conditions themselves. So we talk about, how are we going to identify and improve and optimize? So as a geriatrician, luckily, there's a tool that we use, and it's called, the tool is really called our comprehensive geriatric assessment. And what you'll see is that, number one, this image really shows a few things. Number one, it really just shows how complicated and how interconnected the different domains that we look at in older adults are, and how much one can impact the other. So let me just say, like I mentioned, as a geriatrician, this is sort of the tool that I use in my assessments of older adults to try to get a fuller picture of what my patients or the older adults' needs are, what their issues are, and how we can best support them. So you can see that the domains include physical health. So that are, of course, going to be things like those chronic medical conditions that, we talked about earlier. It'll include medications. It'll include, nutritional issues. It'll include all those sort of, you see here it says giants. Those are all the things that, I look at as a geriatrician, how's it affecting, function, et cetera, things like that. So looking at the physical health, obviously, is going to be a component to it. But where we go in, really delve more into it, I think, is in the other domains. So we look at also the cognitive and emotional health. As I mentioned earlier, we know there can be effects from many issues that might be happening, including chronic health conditions, or just, that might be a primary issue that's been going on as well. So looking at their, mood issues, looking at their cognitive status, looking at, any sort of substance use, it's very, very important. The other thing we look at is social supports. So who's around, who's in that circle of care, what kind of needs does someone have, and are they able to support them? Financial support is going to be very important. As we know, getting older is not cheap. So looking to see, what the standard, what the situation is. I don't need to know exactly what the bank account, balance is, but knowing sort of where people stand is going to be quite important in that aspect of sort of the social support. And then, of course, the external environment is going to be very important as well. That'll be, assessing what, supports they may need, who's available, what's the situation at home, are there stairs, is there, are they able to get around? Who's there to help them? And looking at that environment as well. And putting that all together really does help, number one, take a good picture of what the situation of the patient is and how we can optimize it. And I think one of the, depends on who you ask. We all can agree that an older adult is quite complicated. And that complexity might scare people. But it was actually one of the things that attracted me to the field of geriatrics because of that complexity. And what's nice about the complexity, on the one hand, is complex and things, can get awry quite quickly. But on the other hand, the fact that everything is so interconnected, you actually may be able to, and quite often, optimize one aspect of these domains, which may not be the exact, diabetes or whatever sort of chronic health condition that we talked about. But if we can find some improvement in maybe one of these other areas, because everything is so connected, it can actually have a benefit to those things that we were talking about before, the chronic health conditions. And that is something that I find really, I think, unique and beautiful to geriatrics. And that, I think, is the key to how to manage our older adults with chronic health conditions, looking at the person as a whole and seeing how we can optimize in any of these domains to help people continue living their lives as they intend to, with independence and living well as they get older. So how do we do that? We know that we can identify it. We have tools for that. But then, next steps, what are we going to do? So an interprofessional approach is going to be key. As a geriatrician, I cannot work in a vacuum. I really rely and use a lot of these supports. So that sort of interprofessional team would include a primary care provider, so the GP. And I usually work very closely with the family doctors, as well as these other plethora of supports, including nurses, social work, pharmacists, physiotherapists, occupational therapists, and of course with the patient and with the family or caregivers. And this is really where we can sort of shine and figure out where we can optimize things. Because again, we have our training, our straight training of every specific health condition, and we know, okay, when you have high blood pressure, you need medication. We have diabetes, we need to keep the sugars here, and this. We have that knowledge. But when we look at the person, at the individual, we really have to try to put these things together. And that really, I think, is the key to this. And again, thinking about where those supports are, I think that is going to be sort of the next question, and who to reach out to. So I think family doctors, and that's sort of the maintaining the communication. I think family doctors can be a wonderful support and sort of gateway to this. Us as geriatricians also have that knowledge of who to connect with, because there's so many supports available, at least, especially in Toronto. We do have so many supports available. It always depends on where we are in the community and where you are in the province, in the country, etc. But the, how can I say, home and community care services supports, formerly known as the LIN, formerly known as CCAC, is another great support that we can use, and the connecting. Other great supports in the community as well, specifically in Toronto, is the Toronto Seniors Helpline, which has a lot of information about supports in the community, both looking for private supports, looking for community supports. They also have wonderful supports just on the individual level in counseling. So it's really important that we do try to find those supports, find those linkages to be able to live, like it says here, a long, well-balanced, meaningful life. And these are some of the tips that we include as well. So a healthy perspective, this can be overwhelming, definitely, and trying to be positive and trying to take ownership into what we can do and have that perspective is going to be important, if sometimes hard to get. Having that strong social network. So if you're lucky enough to have a network, have either family, have friends, having a good medical sort of team as well, that can also extend from your social support and social network. It's also going to be quite important. With COVID, we did see how much of an impact being isolated is, and so hopefully as better days come back, we can hope again for that connection to be strong again and be reactivated. But yeah, being isolated with COVID, even without COVID, there are those people who are socially isolated. That's going to be also a difficult point. And again, maintaining that communication with the healthcare team. Sometimes, it's hard to get a hold of people. Sometimes we're afraid to bother people, but it's really thinking about also, respectful, but making sure that we are advocating for ourselves, for our clients, for our patients, for our family members, for ourselves. So those are really going to be important components to it as well. Okay, so I think Cheryl maybe want to say something with here, but I can also. All of these sort of points that we had, and I don't know if Cheryl, you want to, you're welcome to. We have the pamphlets as well, but you might be able to speak to it a little bit better.
So just a resource that really goes nicely with today's presentation. We have it available on our website. So it will talk a little bit about managing chronic conditions and give you some resources that you can access online. So this is just a link for that. Yeah, I don't really have anything else to add for that.
Okay. And this is where I really wanted to spend a good amount of time, and I hope that people have questions, because oftentimes, we speak in generalities, and I really like to get some great questions from you in the audience. So yes, very open to questions.
So that was a great presentation. I think this is such an important topic. I think, managing one chronic condition in of itself can be a task and a big responsibility. But I like your point about as people age, managing multiple chronic conditions and how that becomes complex and complicated. So thank you for sharing that. I think there's a lot of questions that people have, but we'll start off with the first one. The question is, what is polypharmacy?
Okay, so polypharmacy, that's our fancy word of saying multiple medications. The definition of how many medications are you on to be considered polypharmacy. So the general sort of consensus is if you're on, more than, 4 or 5 medications, you are considered to be, having polypharmacy. Does it mean that those medications are inappropriate? No, not necessarily. But there is evidence that shows that the more medications you are on, there's the higher risk of interactions of increased, mortality risks, increased hospitalizations, et cetera. The list can go on of what there could be more risk of. And there's a lot of, polypharmacy could be an entire conversation, an entire lecture in and of itself, but it doesn't take that many medications to be at an increased risk for complications. And that really is what polypharmacy is the increased number of medications that someone is on. And there's things that definitely can do about that. That's one of the aspects of our comprehensive geriatric assessment. And if we have the help of our pharmacists, our colleagues, it's always welcome and helpful to see sort of which medications people should be on, medications that worked before, but maybe now maybe don't need as much, want to look for lowest effective dosages. There's a lot that we can do with polypharmacy.
Thank you. The next question is, could the importance of collateral information be addressed in obtaining this without the patient present to allow for their dignity, but also to support care-patient relationship?
Yeah, so it's a very good, point is getting sort of your full history and that collateral information. So we have to always balance the independence and the privacy of our patients. With the idea that a lot of times with older adults, especially if there's older adults that have cognitive issues, they may not be able to give us a full history. So how do we go about getting collateral information? So the easiest way, and hopefully it works out, is that whenever we have our patients come in, let's say to our clinic, we always encourage and recommend that the patient come in with somebody that they're comfortable with to sort of be with them and give information. So be it, spouse, be it the child, be it the friend, be it the power of attorney, whoever it is, the friend, whoever the patient feels comfortable with, to have someone come in. But whenever I do see that patient, I always ask for permission for that patient from the patient to actually get collateral information. Sometimes the collateral person who we can get collateral from is with us, and we can get that information there. But it's true, there are some sensitive topics that perhaps the patient themselves wouldn't want to speak to in front of them, or maybe there is that that power sort of level of a child or a spouse afraid to comment on things. So asking the patient, just full out, is it okay if I speak to your, whoever it is, your son, your daughter, your husband, your wife, to get a little bit more information if they're there, if they're not there. Oftentimes I will try to get to speak with the patient, to speak with the collateral information person, not with the patient there as well. Because I think there is a lot of good information there, but it's really going to be important to find that balance and making sure that we respect the autonomy of the patient while getting that collateral information. Because like we said, I can't work as in a vacuum. The person also often will need that extra support from people. So it really is finding that balance. And for the most part, people are happy to allow people to sort of share. Otherwise, it's looking at people who are in that circle of care already. So if I will call, family physicians, or I'll call, coordinators from what was formerly called the LIN, and get information that way. Because sometimes you do need to have more information than what the patient may, from no fault of themselves, be able to give.
Thank you. That was a great answer. Another question is, moving to a new community when older and a spouse has passed makes social networking more difficult. Joining, yes, but being a part of a group is something else. Do you have any tips for social networking?
Yeah, so I feel like once we leave school, I find that making that social network is hard in younger adulthood and older adulthood. So yeah, it does become difficult, and also it's sort of a personality component to it as well. I have a lot of patients that are just like, I was never really a social person, and now that I'm alone, they don't even, it's not their natural habitat to go and hey, how you doing? I'm so and so. So I think it really takes effort. So I think that there's a few resources available. So in the community, and again, it depends where you're at. But again, and also what the COVID situation is. So let's say pre-COVID times and hopefully post-COVID times, there are a lot of community centers that have activities and programming for older adults. And the ranges go from older adults just in the community, and there's also specialty programs for people maybe who have cognitive impairment, etc., things like that. But there is a lot of programming in the community as well. Things from community centers, from museums, from sort of movies, things like that. There's a lot out there depending on what the interests are. I think a good resource, at least in Toronto, to get a little bit more information about that would be the Toronto Senior Helpline. They just have, they're sort of the database that I would go to see a community programming, because it's hard to sort of keep track. It depends on the neighborhood, depends on the, cultural background, languages. Things are available, but sometimes very hard to find. There's still going to be that issue of, okay, we have a wonderful amount of programs. How do we sort of get people to do them? So if it's really one that's just sort of geared towards, adults, if you have, a loved one who, needs to be exposed to, some of these things, maybe going with them, maybe, going to part of it, just seeing how it is. It's really that comfort level. Again, we really want to try to refrain from treating older adults as they get over more and more like children and sort of pushing them to do things, because we have to respect their will and their autonomy and what they're comfortable with. But giving suggestions and things like that, I think, would be helpful. And in that big picture, something that also might be helpful is, for specific, if we're talking about chronic health issues, support groups specifically for those chronic health groups, chronic health conditions can also be something that may be appealing to the patient, because there's someone who really understands what's going on. And it could be also, lots of different things. There's exercise type groups, there's more cultural type things, there's more community-based things. So it's really, there is a lot, thankfully, at least in Toronto, a lot of diversity. And again, as you go out and around the province and the country, it'll be different, but that same idea. The other thing, and again, I'm talking long about this, but there's a lot of social supports, I think, especially when people, move into retirement homes. There's sort of a built-in social network. So sometimes that might be a good opportunity for some people, and some people that might be the worst thing in the world to them. So really thinking about, the individual, that might be helpful options as well.
Thank you. We have a question from Dr. Lee. He's asking, how does a CGA correlate with CGS 5 minutes framework? And maybe you could just remind people what that stands for, those two acronyms. And I think a follow-up question to that might be, how does one access a geriatric assessment?
Okay. So the CGS, or the Comprehensive Geriatric Assessment, is that tool that, like I mentioned, that we use. And what's interesting is that there isn't any, at least with that, the CGA, there isn't, and that's one of the criticism with it, not criticism, the thing we work on is that there isn't necessarily a sort of formalized, this is exactly what you do, which is what they're trying to do with things like the CGS, sort of the 5-minute one, which is something that we can actually use in other settings for, not necessarily the geriatrician with capital, G, but, we like to say the geriatricians with the lowercase g. So I think that there is a lot of good evidence of taking aspects of the comprehensive geriatric assessment, which is, again, looking into and assessing all the different domains into sort of a more formalized, shorter version that can be used in multiple settings. And the evidence I can go on and on. I don't have the specific details in them, but I do know that there's really good evidence of reducing mortality, reducing, if it's sort of in a hospital setting, reducing hospital length of stays, reducing, I think, institutionalization, increasing independence. And then when there's a lot of studies when it's used in specific clinic settings. So for example, if it's in sort of an oncology clinic, if it's in, a cardiovascular sort of type clinic, there's a lot of good evidence for that as well. And I guess, so the answer is that it's quite complicated, and I don't have the data off the top of my head, but there is a lot of good evidence for the use of the CGA in and of itself by a geriatrician, the use of all these different sort of more formalized, shorter versions of the CGA, of the Comprehensive Geriatric Assessment, to improve outcomes in various settings. And then I think the second part of the question was, how do we get access to geriatric services? So again, depends on where you are. So in Canada, geriatricians are specialists. I believe there may be just over 300 geriatricians in all of Canada. I think a large proportion, we're lucky, are in Ontario, and getting access to geriatricians depends on where you are. I imagine that the concentration of them, again, are a lot of times in academic settings. So in cities that have sort of university hospital sort of type networks, you'll have geriatricians, although there are many geriatricians also in the community as well. So good resources to find geriatricians is to look for the regional geriatric programs. If you sort of Google that, in Ontario, there are multiple regional geriatric programs. There's of Toronto, there's of Easter, etc. There's a good resource there to see where we have centers in the community. And getting to be seen by a geriatrician requires a referral from, for the most part, another physician. So if going the first step from I would say in the community is asking your family doctor, maybe it's time for me to see a geriatrician, and then started having that referral. There's a lot of different, like I mentioned, points of where you can meet a geriatrician. You can meet them acutely in the hospital. A lot of hospitals, or at least the university hospitals or community hospitals too, do have geriatric services and consultants. There's geriatricians, specifically the geriatrician physicians in clinics. We are also other physicians who have specific training in geriatrics. So for example, the family doctors who did specific care of the elderly training are also available in the community as well. And you can also find geriatrics or geriatric components, and actually specialists too, although not geriatricians, in emergency room within the hospital themselves, of certain sort of ACE units or acute care of the elderly units. So there is geriatrics available. Luckily in Toronto, we have, really a saturation of geriatricians, but I mean, that's relative to the, overall amount of geriatricians that there are. So I'd say the first step would be family doctor assessing and referring. But if you want to sort of know where there are geriatric clinics, regional geriatric programs, you just sort of Google that. So the regional geriatric program of Toronto is a good resource to sort of see where they're at. There's like maps and things like that as well. So that would be sort of a good source.
So just a follow-up question to that, Dr. Steiman. Given that there's not a lot of geriatricians in Canada, if you're in an area that there's not a geriatrician to do the assessment, can these be done virtually?
Yeah, so that's actually one silver lining, I guess we can say, from COVID, is that now geriatricians, I think most of us have gotten a lot of practice with virtual visits. Even before COVID, there was telemedicine clinics available for more remote areas that don't have access to geriatricians in person. So there are a lot of opportunities. So physicians can, through the e-consults hub, can actually make, number one, just sort of virtual referrals there. And there's also opportunity from telehome care to have virtual, actual virtual visits as well. And I think that's something that, and I can imagine there's a lot of specialties that are now, I think going to be gaining from some of the COVID experiences of not being able to see people in person by now using more and more of the virtual technology. Of course, with older adults, some may not have internet, may not have computers, etc., but they may have people who do. And we've even been doing telephone assessments as well. And again, these virtual ones are not going to be perfect, but we still can do a lot of good work virtually. So I think that's one of the silver linings, I think, is making us more comfortable with virtual assessments.
Thank you. Just switching gears a little bit, there's a question. Can you speak in more detail about chronic pain management and use of medications, including non-THC products?
Yes. So pain is a very big chronic condition that could have multiple sort of sources of what's causing the pain. Sometimes we can figure it out, sometimes we can't, and there's sort of these syndromes. So especially with older adults who are more sensitive to some of the side effects of common pain medications, be it from things like Advil all the way up to the more strong pain medications of opioids, we really do have to be sensitive to that and try to optimize it. On the other hand, we also need to make sure that the pain is well controlled, because that has such a big impact on day-to-day functioning, mood, cognition, everything. So it's really finding that balance. So when, on my, approach, when I have an older adult with pain, depending on what the pain is, I usually like to start with more of the well-tolerated pain medications, things like acetaminophen or Tylenol, integrate into that. Maybe what are the reasons for the pain and what can we do, surrounding to support them, be it, physiotherapy, if it's more of like a musculoskeletal type pain, be it mindfulness, going into things like cannabis products. I think that is a great, resource and option. The evidence, again, is still sort of in the works. Personally, I don't have good enough, I would say, for myself, training to prescribe and recommend things, but I do refer them to these types of cannabis clinics for trials, because I think that it is an option. I mean, every medication will have its risks and its benefits. So I think it's worthwhile to try things, but making sure that we're reassessing and seeing how the effects are. So again, the range of types of medications can be from, your classic, like I said, Tylenols, Advils, to the opioids, but there's lots of things in between, things that are more for neuropathic pain or sort of pains of sensation or nerve pain. There's lots of options, and the answer is to sort of start low and go slow, is what we like to say. There's also pain clinics if we really think that it's going sort of beyond where we're at. And I think also another aspect to it is that there could be interventional pain issues, options, injections to joints, things like that. That's also could be options. So really trying to look at the person as a whole, seeing, how they're responding, looking at the potential side effects of these medications, but also really taking into account that it's going to be very important to control the pain as well. So I hope that sort of answered it.
Thank you.
Again, it can be its own lecture on pain control.
I have another question here. Can you speak to aging with a severe mental illness such as bipolar, personality disorders, etc.? How easy is it to identify dementia, for example, in this population?
Yeah, so that's a really good question. And again, thing that I always like to start with is the brain is a very, complex thing. And so people who had, lifelong mental health issues, I sort of consider them as someone who has, who has a vulnerable brain. So when people have vulnerable brains, they're going to be at risk for things like dementia and memory issues. So oftentimes the tests that we can do They are focusing on different aspects of cognition. We can sort of go into, but there's different domains. So there is ways for us to, see, is this part of a sort of cognition aspect to it, or is it part of a mental sort of health primarily issue? And oftentimes it is quite difficult to pare it, down. I think that finding out what sort of the etiology or the cause of some of the issues that are going on is going to be one fact and one sort of thing that we want to look into. And oftentimes when it does have very much a psychiatric or primary psychiatric component to it, I definitely do not hesitate to reach out to my colleagues, the geriatric psychiatrists, who are going to be obviously really focused on that and have that knowledge of the general sort of psychiatric history on top of the dementia components. So that's a really good resource, is geriatric psychiatry, which I really, like I said, I don't hesitate to refer to. But on the other hand, there is sort of trying to figure out, what's sort of causing it, et cetera. But on the other hand, well, we see that something's going on. How can we support it? How can we make sure that, if they are at baseline having issues with taking their medication, they're not able to, take care of their sort of basic, day-to-day needs, like, taking care of their finances, taking care of their, their needs. How can we support that? I don't necessarily need to have that clear answer yet for me to be able to help and support them. So it's sort of taking two things and looking at it two approaches and sort of to optimize it. That, trying to figure out what's the cause and how we can sort of, pinpoint and treat in that regard versus, how can we sort of support them in all the other things other than like, the classic treatment for them. So it does get complicated. And yeah, sometimes we won't be able to sort of separate them, and sometimes we would be able to sort of clearly see, but it's going to be people who have mental health issues, lifelong, will be at higher risk for a lot of these syndromes that we see in older adults.
Thank you. We have a number of questions about falls. I might summarize it by saying, can you talk a little bit about the link between chronic conditions and falls, and then for older adults who have had a serious injury due to a fall, how do they regain their mobility or their confidence in getting around?
Yeah, so falls are a big, we call it geriatric giant, something we see and deal with quite a bit. And you can imagine that it's a significant aspect and concern to people. So falls, again, like many things in geriatrics, is very much multifactorial. And having one of the big aspects is sort of those chronic medical conditions and how each of those things can impact falls. So having that assessed at a falls clinic, or by maybe, if you really sort of identify it and asking the family doctor to reassess, looking at those aspects and seeing how we can optimize them. If some of them are modifiable, how we can modify them. So we are looking to see, if that history of a stroke is the history of, vision issues, sensory issues. We look at all those things and how it can affect them, and seeing if there's anything we can optimize. So for example, is this patient, has a history of high blood pressure, and now their medications are maybe too well controlling their blood pressure and they're fainting all the time? That's one thing we can do and reassess. So really going through using our components of our comprehensive geriatric assessment can identify these things so that we can at least reduce that risk. So that's sort of one risk reduction. And then the other thing that we can also do, and what's quite important, that's been shown to reduce risks of future falls, is balance and exercise training. So we have these fall prevention programs. We have very formal ones through sort of the university and medical sort of led. For example, we have the Toronto Rehab. There's throughout the city, there's quite a few of them that are associated with, hospitals and clinics. And then there's a lot of community ones that, again, are probably on hold because of COVID, that are associated, that are, based out of community centers, et cetera. So finding those balance and exercise type programs specifically for fall prevention. And another one that I'll mention is something like Tai Chi, is going to be quite important. Associated with that and that education around falls will be that confidence. And learning how to, sort of strengthen those exercises oftentimes will hopefully lead to that increased confidence. Getting the right gait aid, getting the right, supports at home with, grab bars and things like that, making sure you have the right shoes those are all things that hopefully will, number one, reduce the risk of falls, but also increase in that confidence. So that is a very big component of sort of rebuilding that strength and balance sort of in training. And it's very, very easy to lose that strength, to sort of decondition, and it's much harder to gain it. So it is a process.
Thank you. I have another question here. Could you share a couple of examples of common comorbidities that perhaps clash in their plan of care, and how do you navigate this? Okay,
so oftentimes, this is one that sort of we see quite often, that, and this sort of goes with a lot of times with medications. Oftentimes you'll see people who have, let's say they have high blood pressure, they get put on some, blood pressure medications. And some blood pressure medications might have side effects, or maybe there's other medication that they're on, let's say for pain, they get put on, let's say Advil or one of these types of medications, and it leads to more high blood pressure. And then you have this cycle of, well, let's put you on more blood pressure medications, then your blood pressure drops and you're falling, and then you have all these sort of this cascade, and it's called, one specific example is this prescribing cascade. That we see it in so many different aspects. So, for example, in urinary incontinence, sometimes you will get medications to help, curb that. And a lot of these medications have effects that result in increased confusion and things like that, because they're what we call anticholinergic, or these sort of effects, which specifically how they help with urination, also causes things like confusion, increased risk of falls, etc. So you have all these times when you're trying rightfully and with no malice, trying to help certain medical conditions that lead to other problems, and it's sort of trying to disentangle that and see if there's other alternatives that maybe we don't use medication, maybe we'll use sort of some behavioral type treatments instead. Same thing that you see a lot of times with pain medications, where you have a lot of pain and you try to give medication, and then they're very sedated, and then they're not active, and then they become deconditioned, and then they're falling, and then etc. So it's just, everything is so interconnected, that we see that all the time. And what we often try to do is we try to find the sort of things that are easily identified and easy to modify. Because it's going to be really hard to say, okay, well, you have high blood pressure, I'm not going to be able to, take that away, or you had a stroke and you have, residual weakness. It's going to be hard for me to modify that, but I can optimize your medication. I can try lowest effective doses. I can send you to, get some rehab. I can do those types of things, get you some, a gait aid, etc. So those are what we're really trying to do. But everything is so interconnected, that it's really, really important to try to disentangle it. Thank you. We have some participants that are not from the Toronto area, and you made some reference to some local GTA resources, but in terms of things like getting help with community support services or finding a geriatrician, do you have any recommendations for people that are in other parts of the province? Yes. So what you definitely, always the first source that I would recommend is connecting with your local home care and community, the LIN, your LIN services. So that's sort of the home care supports of the province. There's sub-regions throughout the entire province. If you look them up, I don't have their website on the top of my head, but I believe the phone number is, I don't know the phone number either off the top of my head, of course. But we can definitely, if someone specifically wants to know, we can find them. That is I would say the regional source that I would go to first, because that is one of the things that the coordinators are doing and trained to do, is to sort of help make those community linkages. So they would be able to have a good resource for you. And then, like I mentioned before, the regional geriatric programs, they're spread over all of Ontario. So you just have to find the region that you're in, and there you'll be able to find some resources there. And it also just depends on what sort of program you're sort of looking for. For example, Alzheimer's societies are also regional. Toronto has its own, but there are, out of Toronto, it goes by region. And we see this often where, in Toronto, we are so resource rich, and then out of Toronto, things have changed, and we really need to think about the equity in regards to that. But I would say the first source would be what is contacting the LIN, which is now the home HCCSS, I believe, is their home care and community. So I think that's going to be important. And I think now more, again, with COVID, I think more and more programs have, virtual components, and that will probably, lengthen the reach of some of these programs. But at baseline, I would say those LIN supports would be the first resource. That is really quite regional.
So the LIN has changed its name, but I think the number is the same. I think it's 310 CCAC, if you call that number.
Exactly. You don't need a code even.
Yeah, I also think that 211 might be a good resource for finding out about health and community social services, and that number is consistent across the province. I have another question here. Can you advise on treatment for arthritis of the knees?
Yeah, so I think this is going to be, again, the sort of general approach to pain. With arthritis, there's a few options. There's the medication sort of route, where, again, always wanting to start with things that are well tolerated with least side effects. So in our geriatric population, that's going to be things like Tylenol, but also the things that could be more topical, creams, etc. Voltaren, icy, whatever sort of people want to buy and try, usually are quite safe, especially if they're sort of topical. What's nice about arthritis, I guess, is that you can also have good supports with exercises or strengthening the muscles surrounding that joint. So being connected to physiotherapy, I think, would be also a really great option. Other things that you can be connected with are physicians that can include either family doctors, some of them are trained, orthopedic surgeons, physiatrists, who may do injections, local injections of various things. Usually they're steroids to try to reduce that inflammation. So there's lots of options there, but it takes work. Yeah, Cheryl, next.
Thank you.
Yeah.
Sorry, I've got the hospital announcement here, so you don't want to hear about the codes. So I'm going to speak quickly and then I'm going to mute. Can you speak to how young onset dementia differs from dementia that develops at a later age, and what types of supports are available for young onset dementia?
Okay, so yeah, usually we think of dementia as a condition of older adults, and for the majority of cases it is. But there are various more, I would say, uncommon causes and of younger onset dementias. And again, dementia is sort of that umbrella category, and there's different types. There's Alzheimer's dementia, which again usually happens in older adults, although can occur in younger. There's things called Lewy body dementia. There's frontotemporal. There's lots of different types of dementias that we can go over and through. And what's interesting about them is there's more prevalence that it could happen in younger adults, and then others that it happen in older adults. But really, the age is not necessarily the defining feature. It's sort of how the dementia presents. As I sort of alluded to before, cognition is not just memory. There's lots of different domains of cognition. So there's memory, there's language, there's how we do certain acts, there's the sort of executive processing. So there's lots of different aspects to it. And there's a certain pattern with each type of a dementia. So age alone is not sort of the indication for it, but there are certain ones that are more prevalent in younger adults. So would that be a barrier for them to be seen by, let's say, a geriatrician who has a lot of good resources for older adults who have dementia? Could that be extended to younger adults? So a lot of the issues that people have surrounding dementia, it will happen to younger adults too, the supports that they may need. So for the most part with us and geriatricians, we do see, for us, the official diagnosis, the official age of geriatrics is 65. But if it is an issue of dementia, we actually do see younger adults less than the age of 65. So if there is someone who has a concern that there may be a dementia and want to be assessed by, us geriatricians, or, already been assessed and diagnosed, let's say by a neurologist, because maybe that's something that's not a barrier with age, one thinks, but you would like to see a geriatrician to help with sort of the other sort of components to it, we can. And we do see younger adults. And oftentimes, again, depending on what the program is, usually it'll extend to younger adults if they have, these syndromes of sort of dementia, et cetera. So age shouldn't be the absolute draw of what these supports come in. It's more of what is the diagnosis, what are the issues and supports that a person needs. So yes, I've seen people with early onset dementias. For the most part, they're not coming to geriatricians to get that diagnosis because they're younger. Oftentimes they're going to be seen by neurologists who also have training and specialize in dementias as well. So oftentimes they won't be diagnosed by us, not necessarily, but the needs that they have seem to be appropriate for coming to see a geriatrician. And a lot of the supports that we'll need will be extended for that as well. It depends on the program, at least for the support programs. But for the most part, finding those supports are there, maybe a little bit harder.
I think we have time for 2 more questions. So the second last question is, for the population of developmentally delayed adults who typically age faster, what would be a recommended age or key indicators to seek out a CGA?
Okay, so this is sort of a similar issue of is age the indication for when you could see geriatrics. So when there are sort of these developmental delays type things, again, a lot of the supports and concerns, and again, sometimes the physiology also results in more sort of geriatric syndromes. I don't think it's unreasonable to seek out a geriatrician. Although I would say that, and I would hope that the community supports, specifically for adults with special needs or with sort of developmental delays, would be able to help carry out with some of those supports, et cetera, needed. But I would say, because it's really hard if there is someone who's 45 and should they see geriatrics, it's sometimes hard to say, although because the cause of it is not necessarily a dementia, it's a different issue. So it might not be that actually might be a time when the specific support and the assessment for the cognitive part of it may not be as helpful from us geriatricians, because we're not used to dealing with that, and that's on our training. That being said, I think maybe getting some of the supports may actually still be applicable. But I would say probably in that regard, I would I would maybe try to find more community supports surrounding developmental delays and cognitive sort of I guess changes, delays, etc., in the community rather than geriatricians. It's sort of hard. Age shouldn't be, and it isn't always that sort of black and white, but when you get to the really quite younger and it's not a primary sort of dementia picture, that's when it gets that maybe our expertise to help connect the patient may not be as helpful.
Thank you. I think we've all done really well to not mention the COVID word during the last hour, but we do have a question I think it's important to answer. So one of our participants is a 78-year-old female. She's asking, how long after the second COVID vaccine until safe to see my family? 2 or 3 weeks, ? Just heard this morning, I live alone and every day makes a difference, but want to be safe. So what would your best recommendation be for her, Dr. Steiman?
So I first of all have to say that I can imagine this has been really a difficult year for all of us, and specifically for our older adults who became quite isolated, and the risk associated with COVID for our older adults has been quite severe, and the results quite devastating. So yeah, so now we're asking questions about vaccines and things. I think that's a nice change and positive, effect. So I think it's going to be important for us to wait for the advisory councils to give us the recommendations for seeing family after getting our second vaccine. We already have some guidance to people who live in long-term care about visitors there. How there is, I believe there's, everyone's vaccinated, there is more opportunity to even, embrace and hug and things like that. I think that definitely 2 weeks after receiving the vaccine, and this is based on sort of data that's, from other places and sort of guidance from other places, i.e. CDC guidance in the United States, usually there's about 2 weeks is where we'll get that, steady state of the immunity. That being said, I would say that until we get clear guidance from our advisory, the vaccine advisory sort of committees, I would continue with the recommendations that we have so far now. So if you are living by yourself and you are sort of bubbling with one other household, making sure that maybe still staying outside, maybe still wearing masks until we get that okay of when we can actually see people who are both doubly vaccinated. I think that it's coming. We're going to have to get these guidance soon because more and more of us are getting, thankfully, our second dosages. And I think soon we'll have that guidance there. And I imagine it'll probably be similar to the guidance in the United States, where fully vaccinated people, and I think they said after 2 weeks after getting the vaccine, can see each other barrier-free, and even in indoors. So I'm hoping that's where we're going to go and where we're going to be. But until then, now that the weather's nicer, I think we have opportunities to still be safe until we get that clearance.
That sounds like really good advice. I think we're going to close the question and answers now. And I just want to thank Dr. Steiman for your time, your energy, being able to answer all of the questions. I think that everybody, all of the feedback that we're receiving, that it's been very, very helpful. And I would just like to thank everybody for joining us today. If you are one of our regular participants, I want to let you know that we will not be having any sessions over the summer, but we will be back in September with a nice fall lineup for you. And also we have all of our resources, and the ones that we mentioned today are on our website under health education at sinaigeriatrics.ca. If you want to get regular updates on what's going on with us, follow us on Twitter at Sinai Geriatrics. And for any of you that are interested in some professional education, we have an upcoming Geriatric Institute Day on June 24th. The theme is Back to the Future, talking about applying COVID-19 learnings to transform the future of geriatric care. We still have about 50 seats open for this. Registration fee is $25, so you're welcome to join us at that event. It's going to be really, really relevant and very timely for a lot of our health themes right now. So again, I'd like to thank Dr. Steiman. I'd like to thank the Healthy Aging team led by Asenath, who is our producer behind the scenes and keeping us on track. So thank you so much, everybody. Have a safe summer, and we'll see you again in September.